Afternoon, everyone. Thank you so much for joining us and for taking some time out to celebrate this occasion with us. So, Prof. Eugene Clutter, who is our Vice Rector of Research, Innovation and Postgrad Studies, he couldn't be here, but he was kind enough to share some welcoming words, which I will share with you now.
Welcome to all of you to the launch of the Research Bronchoscopy Suite. Thank you, Professor Walzl, for inviting me to say a few words of welcome. Special word of welcome also to our rector, Professor Wim de Villiers, Dr. Keith Clutter, Dr. Nkosi, who's the CEO of the Tygerberg Academic Hospital. It really is good for me to be here this afternoon and to say a few words. It's been a tough year for all of us, specifically for those in the medical field. We, as a university and leadership, rapidly pivoted to support the national testing program, especially from our core Center of Excellent Perspectives, where we had representation on the Ministerial Advisory Council on COVID, and we also played a very important role in modeling of the pandemic. However, our research focus has been redirected away from core activities for over 8 months now. Our students and staff have been displaced from laboratories, especially in cases where lab infrastructure has been diverted to supporting COVID work. Clinical studies were halted countrywide, and there's been an inconsistent provincial approach to reopening these. We also had a problem with reagents and consumables that have been in short supply due to travel restrictions. Many of our students and staff experience a financial and mental strain due to the lockdown and social restriction of movement. General exhaustion among academics who have been called on to assist in different roles has been observed. We've also experienced delayed payment and cutting of budgets from our funding agencies, and just overall a lot of strain in coping with new operational modalities, going online for teaching, blended learning, working with university support services remotely, and so forth. However, today we are in a very fortunate position that we can celebrate the launch of a new research facility. The Biomedical Research Institute building was commissioned approximately 2 years ago and has recently been completed to the point where we can start occupying some of the facilities. So due to the COVID epidemic, our research bronchoscopies in Tygerberg Hospital were halted as the theatre space was needed for COVID patient care. We did, however, have several important research contracts that required research bronchoscopies to be conducted. To allow research to continue and to achieve independence from the hospital, we established such a facility in the faculty. The research suite will enable cutting-edge research on samples from the site of disease of a range of conditions, including tuberculosis. The suite is part of a continuum of high-tech research infrastructure that also includes the research PET-CT facility that we launched last year, the BIOS biorepository, and the immunology laboratories in the BMRI. I want to congratulate the team with this new initiative. I wish them well, and may they spend many productive hours in this new research facility. And I thank you again for the invitation to say a few words. Thank you very much, and goodbye.
So we are the Biomedical Research Institute clinical team. We recently changed our name. Our team has grown a lot over the last couple of years. This picture is already outdated, and difficult these days to get a nice group picture like that. But we are really a multidisciplinary team, and you need that to do proper clinical research. So for our development, we really developed out of the immunology research group, which was established in 2002. The original focus was on laboratory science with infectious disease and immune responses, but the translational potential was always there. And over time, the IOG went into more, developed their own clinical recruitment. Started with, in 2009, with just 6 clinical team members. In 2014, arbitrarily, the molecular biology clinical research unit was established. The members roughly doubled, and we also started planning for trial readiness. And in 2017, we started with our first trial, moved to new facilities, and there was also at that stage about 50 members, and we also completed the first clinical doctorate, which was my own. Now I've got a couple others on the way. Currently, I'm in this year, to preempt the move to the BMRI, we changed our name to the BMRI clinical team. So our main focus is infectious disease research, and in particular tuberculosis research and research translation. So research translation is not just the kind of the classical model of starting from preclinical and moving to clinical, but it's really a constant dialogue between what's happening in clinical practice, and using the science to explain what's happening there, and also using the science to suggest possible interventions to the observations that you make in clinical practice. And for this conversation to happen, you need a good clinical research, discovery, and evaluation team. And that's really our focus. So we're there to tie what's happening in the lab, and these days more and more also on the computer systems, to what's happening in the communities and in the hospitals and clinics. For that to happen seamlessly, we need infrastructure that can really reach into the communities. But so you need some form of mobility, but then also infrastructure to really ensure a very, very high level of documentation, record keeping, data capturing, and also patient or participant care. We've developed a couple of niche areas of interest. One would be the PET-CT scans. So that's the functional scan that really gives that brought a lot of new insights into the site of disease. And we do that in partnership with the BMRI Node for Infectious Imaging team, and also biomedical engineering, because part of it's quite challenging to do these PET-CTs, and part of that is forming the PET-CT, planning and getting all of the logistics ready, and then also very importantly the proper analysis of very complex three-dimensional data. And then recent bronchoscopies, which provides a site of disease sample, and that's been we've been doing that in partnership with the Tygerberg Academic Hospital and the Bronx there for more than 10 years. But the demand the demand has grown for that, and it's really been shown to potentially lead to a lot of new breakthroughs and new insights. And this, our involvement in this niche area of interest really directly allowed us to bring in a lot of grant money, and that's also both necessitated and allowed us to expand more and more, get more and more of our own staff, and really now our own bronchoscopy. Well, thanks to everybody, the support that we get from the university structures and the PIs bringing the money, and the clinical team and the lab team, and everybody really working together to make this a possibility. And I think we can do great things. Thank you very much.
Yeah, so I must say the clinical group is really an essential part keeping the BMRI sustainable. I would say roughly 50% of the annual income, grant income from our division comes via the clinical team in some way or other. It's not out and out clinical study that brings in that money, but if Andre writes a grant, the clinical team is an essential part thereof, etc. So, why bronchoscopy to study tuberculosis? Well, it is, these days, the primary site of disease. It used to be the primary site of disease was in the gut before milk was pasteurized. And these days, of course, the lung is both the primary site of infection and also the source of transmission. Site of disease responses can obviously be different to peripheral blood responses. So it doesn't help to search for your lost key only under the street light. Sometimes you have to go and look a bit wider. So that is why site of disease responses are becoming more and more important to study. And the lung also has an alveolar macrophage population that can be crucial to the outcome of many infections. And the reason why the lung is so different there is its primary function is actually to breathe and not to fight infection. And it needs to play a very careful balancing act between maintaining gas exchange ability and fighting off any invaders. The lung filters, I think, about 15,000 liters of air a day. Is that right, Brian? Well, pulmonologist says so, it must be right. That's quite a lot of air that needs to be cleared of microbes. And the alveolar macrophage is a very special type of cell. It will engulf those microbes, but it won't go crazy and won't overreact. And some pathogens like TB will exploit that, and they will particularly target these macrophages, who will not lead to out and out warfare against these pathogens, and they will use them as an entry point into the body. The other thing is the bronchial tree represents a mucosal surface, and one that is quite rich in retrievable immune cells. So you can get hold of immune cells in that mucosal area. It's actually much more difficult to do that in the gut, for instance, because the gut is so long, and it is difficult to sample enough mucosal immune cells from that particular organ. And the other thing is, bronchoscopy is a well-established, relatively safe endoscopic procedure. So Evan might ask, what on earth is a bloody bronchoscopy? So bronchoscopy is an endoscopic procedure where we insert the camera, as the lay people call it. Actually, it used to be a fiber optic instrument. These days it has a disc, a device in front, a charge-coupled device in front that actually electronically transmits the image information back to, as you will see, those who go on the tour, to an image processor. So the patient is sedated, not anesthetized really, so it's conscious sedation. So that's more or less like after half a bottle of whiskey for the average student. At least in first year. By third year they have accommodated and need more. And then you push that tube into the segment of the lung of interest. Here you see on the left, you see our first bronchoscopy that happened yesterday. And in the middle, you see an image taken with the bronchoscope in the right middle lobe. And if you look carefully on top of that round image, there appears to be an air bubble. And indeed, that is an air bubble. And the rest of that segment is flooded with normal saline, with water, that we inject and retrieve again. So we inject about a cup of saline, 240 mils in this case, and then we gently aspirate that again. And then this water that we've injected contains immune cells that were present in the periphery of the lung. And on the right, you can see examples of such cells. They are mainly macrophages, but during different types of infections, there will be other cells as well. In bacterial pneumonia, you get a lot of neutrophils, and in TB, there might be more lymphocytes, and then there are these interstitial lung diseases that will also often have a lot of lymphocytes present. So our research bronchoscopy history goes back a few years. So we started with this probably 5-6 years ago. And strangely enough, we started by working with UCT and doing bronchoscopies for UCT research teams. And the first paper was in 2016 on HIV, and subsequently we started getting our own publications, including Farney's PhD, which went to Nature Medicine, which contained some data on bronchoscopy at the end of TB treatment. So we have a history in this, and we've done a couple of hundred of research bronchoscopies to date. And we were working in close collaboration with the pulmonology division of Brian Allwood, Elvis Irison, Kuni Kuchlenberg, and their team. And that was, I think, a very fruitful collaboration. But then COVID happened, and the A5 bronchoscopy theatre was converted to a COVID-19 ward, and we couldn't scope there anymore. But we had a lot of studies that were still ongoing that needed bronchoscopy. In any case, scheduling of these research procedures has always been an issue because patients come first. So clinical service first, which means the bronchoscopies for our research studies have to happen in the afternoon, which means that people like Ilana, in those days, before she became a project coordinator, have to stay after hours and process samples for hours and hours, often in the BSL-3 lab. So that wasn't ideal. And then there was gradually a massive increase in demand for the research grants. There's also a need of such a theatre to be in close proximity to the modern labs, and believe it or not, but walking from the bronchoscopy theatre at A5 all the way to our labs, it is not all that straightforward. So we needed something in close proximity to the modern BMRI labs. So we have multiple grants requiring bronchoscopies. I think there are 6 that I'm going to list here. I'm not going to go through them, but they are mostly in collaboration with US sites, and all of these are funded by the National Institute of Health of the US. And in total, for over the next 5 years, these grants bring in $6.5 billion US, which is almost 100 million rand. And that money goes towards publications, goes towards staffing. I would say that 80% of our staff is funded through these grants. So this is important to provide job opportunities. It's important for us to retain important and crucial knowledge in our environment, and we use that money to update equipment, etc. So this type of funding is very important to us. So we needed a new space, and that's what we got. So what we do with all those cells, here's a workflow. You don't have to look at the detail, but we look both at blood and as an easily obtainable sample type, and we look at bowel bronchoalveolar lavage, which is the fluid that we aspirate from the bronchoscopies. Now we can store those cells, we can store the cell-free fraction of the bowel, and we have a range of different techniques that we have set up, and we can do immunohistochemistry, we can do a look at RNA, both RNA sequencing, single-cell RNA sequencing, flow cytometry, We can look at CFUs as colony-forming units of TB. We can look at cytokine levels. And the group of Professor Nelita Duplessis at the back, they have set up several of these very interesting techniques, including the CyTOF technology, which is a technology that uses rare metals to bind to antibodies. And the advantage of that whole process is that you can look at 40, 50 markers in the same sample at the same time. And the other issue we've had with ordinary flow cytometry in our population is that probably due to smoking and a lot of carbon in those alveolar macrophages, we can't use conventional flow cytometry because of the so-called autofluorescence that these cells have. And the CyTOF technology eliminates that autofluorescence. Nelita, were you the first to publish on CyTOF in Bell or not really? Okay. Tell them to hurry up. So again, then these three ladies here, Nelita, Caroline Beltran, and Lee Kotzer, who's somewhere here. There she is. They have set up this, I think, very cool model where they take these alveolar macrophages, they label them with a magnetic nanoparticle, they apply a magnetic field and then infect these cells, and then they clump together and form the nidus of a granuloma. A granuloma is a cluster of cells, and as you see in that large image, it has a core, and that core is usually made up of these macrophages, and surrounding that core are lymphocytes. Now these lymphocytes are coming from the peripheral blood, and what they have managed to do is develop this model that mimics the body's immune response against, for instance, tuberculosis. And they can follow the development of these granulomas in a petri dish. So this is all cutting-edge stuff that has led to several large grants, and that can only be done if we have a regular supply of samples from a range of different clinical phenotypes. So those are people with TB infection, without disease, those with disease, and so on. So who made this possible? Firstly, the faculty, through making space available, and for strategic funding that went towards the purchase of equipment. The funders have had a lot of patience with us because we did nothing for the last year. We sat on our hands, right? Not really, but we couldn't do many bronchoscopies. So the funders have been very patient. The facilities management, and Charmaine Klein and her team, who did the building alterations. The Tygerberg Hospital Division of Pulmonology for making bronchoscopy theatres available whenever possible, and for years and years of collaboration. And then I must mention, let me get the names right. Firstly, Mark Rubille and Brad Inch from IDESA, an engineering company that built us brand new, out of the box drying cabinets for the bronchoscopes, which would have cost us about 5 times more if we purchased those commercially. And you can have a look, well, they're also commercial, but if you buy from the big companies, it would have cost us 5 times more. And you'll see when you go on the tour how professional these things are. And they also made these hoods that you have seen and we'll see on the tour, that make us look a bit like a scorpion who stuck its own tail into his head. These are for COVID protection. So these are personalized air supply via HEPA filters to make the staff as safe as possible regarding COVID transmission. So, and then also Mr. Jacobs, who provided a lot of information, a lot of help with the purchase of essential equipment. And one of our pulmonologists, where is he? Donald. There you are. Difficult to spot.
So dark.
Donald said yesterday he was present at that first bronchoscopy. He said that is the nicest bronchoscopy theatre he's been in. Not because it's so big and luxurious, but because it is built for the purpose. Is that correct?
Yes.
So I want to thank the BMRI clinical research team. We put them under a lot of pressure. And I think Henriette, where is Henriette? She needs a special thank you because she has really gotten all the quotes, organized everything. She's done a fantastic job. She's a highly organized person. Thank you, Henriette. And then the rest of the team, Jane and Donald, who are pulmonologists and who gave us a lot of insight and practical advice. Candice and Tracy are other doctors who also are involved with the sedation of patients, etc. And then also the unthanked heroes behind the scenes, Donovan Bikes, who had to juggle the budgets. Danny, where's Danny? Oh, there she's behind the phone. Danny for organizing this event and for making sure that our public relations are up to date. Ilana for organizing many things around this bronchoscopy suite. Thank you very much. Susanna, who is always present. Now, this is the best picture I could find of Lauren Benting, our research bronchoscopy nurse. She's not on our website yet. That is a big mistake. She doesn't always look like this. And then I thank you all for your attendance and also for those attending online. Thank you for listening, and over to Nico.
Thank you, colleagues. Good afternoon, and thank you very much for the invitation to be here. It's a great pleasure to be here at the opening ceremony of the BMRI bronchoscopy suite, and housed in our Division of Molecular Biology and Human Genetics, which is also part of the Biomedical Research Institute. So, as you all know, Africa bears the brunt of the global burden of disease. We have a number of colliding epidemics and pandemics currently on this continent, across the continent, and one of these is the scourge of tuberculosis, which in fact is one of the biggest, or if not the biggest, ongoing global pandemic and has killed more than 1 billion people, with about 1.5 million people dying each year. So that is an oft overlooked fact, and the reason why we actually focus quite a bit on tuberculosis in this faculty. So with one of the top medical faculties in Africa, it is our responsibility to understand this disease and others that has an impact on the continent, and we endeavor to ensure that we find out as much as possible, that we do as much as possible research on this disease and make an impact on the lives of our citizens of this country and the continent. So as you've heard now in these talks, the suite or the facility will pave the way for disease research in lung diseases, specifically tuberculosis, but that's in close proximity to other units and centers and facilities in the faculty that provide support, that, as you saw, collaborate and interact with this facility. And I think and then of course also with the communities which are close by, which is a wonderful thing to have, and that is something that many other facilities worldwide is quite jealous of. So our brand new BMRI is also close by, and this facility forms part of that entity. It's a 1 billion rand new building that we are setting up, which will be completed in 2022. We've finished the first half of that project, and as you've heard, some of the departments, divisions have already moved into the new part, and we have the promise of having one of the most advanced biomedical research units in the country, or in Africa for that matter, when this facility is finished. We're very excited with this building and everything surrounding it. And we hope that this will realize, or help us to realize our vision of becoming Africa's top medical research institution, the leading research-intensive university, as is our university's vision, and that we would be able, through this facility, advance knowledge in service of society. So when we look at the facilities that the faculty has supported through this initiative, it forms part of a range of research laboratories. We have a huge biosafety level 3 facility that's being set up, bioinformatics hub, electron microscopy laboratories, proteomics and fax laboratories, medical morphology center, and then the biorepository, which I saw was part of your planned tour just now, or biobank, if you want to call it that way, which will have storage capacity for medical tissue samples of more than 5 million medical samples. And this is also the first automated biobank of its kind in Africa, which will store the samples at -80 degrees for long term. We will have the Sunskill laboratory, we will have the clinical research unit and conference facilities, and so this is quite an exciting facility that we are setting up here. We've heard the importance of TB research and the importance of this for our institution. We do know that it has a huge impact on our country and our continent, and therefore this facility is of critical importance for us. So this department and division where this entity is situated has a long track record of TB research. In fact, it's got the distinction of being Department of Science and Technology National Research Foundation Center of Excellence for Biomedical TB Research, as well as a Medical Research Council Center of Excellence in TB, or Center for TB Research. It hosts a number of research groups on tuberculosis of different, with different focus areas, from animal tuberculosis right through to the clinical research team, and also as probably one of the biggest, one of the biggest, if not the biggest, sample collections of tuberculosis related samples in the world. And definitely in the Southern Hemisphere, with over 10,000 drug susceptible and 35,000 drug resistant cultures in the collection. So our faculty has a long reputation of research, and specifically research on tuberculosis. It is our strongest research area, and we are very proud of that. We have created this research-rich environment, and we have extensive international collaborations, and you saw the number of grants only on this specific area. There are obviously many more, and we sign new grants on a weekly basis, and therefore we are very excited with the future and what this unit can bring to the table for us. And this facility aligns with what we try to do, and therefore we support it, and we're happy to be able to open the facility today. Thank you very much.
Okay, here a bit, and then this would be sort of the step of the bronchoscopy, and on this is obviously where the image is displayed to allow us to see what we're doing. We are quite unique. At Tygerberg, we didn't have low pressure suction. When you work with aerosolized bags that can aerosolize, then ideally you want a low pressure suction that takes it out. This theatre was both with low pressure suction. During the COVID time, we're taking extra care in this theatre, so we are very sure that none of us will get tuberculosis. So all doctors, including Prof, will have, where's mine? Will sort of have a key part which we put up and look like little spacemen when we do it. We have to discuss the labs, so the people who come to collect the specimens, we need to have one of them, or when they come into theatre to have this. There was an oversight from our side. Otherwise, so we want our participants to be very safe, so we've got a defibrillator should they develop heart disorder. In my 4 years of being a pulmonologist, I've never seen it, and somebody told us this morning we will never use that. We do a full vital monitoring while we do all that. Here is the device that Prof was talking about, our dryer machine that we gyroscope with. And I think it costs $500,000 outside. We bought it for 20% of the price. The engineers that designed it, and this is the washing machine for the bronchoscopes. So when we're done with the scope here, we take the patients here to this cover. This is the recovery room. We want our participants to be safe, so we continue to monitor them. They're fully awake when they come out, but we monitor them here. There are 2 participants at the time that we stay here. We put sort of a divide here. TB risk here is reduced because we've got these UV devices here that sort of will switch on when there are participants in here. We've got fridges for our drugs that we use that need to be kept in the fridge. We will ideally see where they work. The flow would be they come in, we see them there, the consent will have been signed a week ago, we put up drips, we take them in theater and then they come out this way.